Here are my disclosures. I'm a full-time employee of CDC NIOSH. I don't have any commercial disclosures. And I think folks on the phone here know this, but just a bit about what NIOSH is. NIOSH, where I work for, is in the Department of Health and Human Services. We're part of CDC. We do research and make recommendations. We often get confused with folks from the Department of Labor. We often get confused with OSHA. OSHA and MSHA are part of the Department of Labor, and they do regulation and enforcement. OSHA in general industry and construction, and MSHA in mining. So here are the learning objectives for today. To recognize the patterns of disease that are associated with inhaling respirable crystalline silica, and we'll get a little bit into what that is. To become familiar with recent silicosis surveillance findings, to recognize the types of work settings where contemporary respiratory crystalline silica exposure and silicosis can occur. And then finally, to learn a bit about preventing silicosis. It's really important to prevent silicosis since there's really no specific treatment for it. So really the best we can do for folks is to prevent it. So a bit of introduction. This is a disease that's been recognized since ancient times. Silicosis is a type of pneumoconiosis. Those are lung diseases that are caused by long-term inhalation of dusts, especially mineral or metallic dusts. Hippocrates described breathing disorders in metal diggers in 400 BC, so this has been known for a long time. 1556, you see this quote from Agricola about dust stirred up by digging penetrates into the windpipes and lungs, produces difficulty in breathing. And in 1700, Ramazzini recommended good ventilation in the dusty trades and that workers quit at first sign of lung disease. So secondary prevention, already in 1700, people knew about that. I'm going to show you a quick historical video here. Hopefully this will play. Can you guys hear this? You're not able to hear it?
I cannot.
Okay, it's not playing. All right, well then I'm going to stop it then.
We can see it, we just can't hear anything.
Okay, so this is a presentation from the U.S. Department of Labor from 1938. And in 1938, they already knew about silicosis. That was the Gully Tunnel disaster had occurred and had caused a great deal of concern across the country about silicosis. And this particular video was from the Department of Labor at that time when they already knew about things like ventilation controls and wet cutting and things that could be done to prevent silicosis. And we're already recommending kind of the same things that we recommend now, but the disease still persists. The next slide that I was going to show you, and since the audio is not working on this, the next slide that I was going to show you, and hopefully you can see this, you can see this clip from YouTube, was a short presentation. I took a clip of two artificial stone countertop workers from Los Angeles who had advanced silicosis. This was just from earlier this year. These poor guys were cutting stone countertop, generating clouds of dust, had no protections, had no training about avoiding those exposures, developed severe disease, and showing that despite our really knowing about how to prevent this disease, at least since 1938 in the modern era, and really having people having known about it for hundreds of years, it still persists.
Workers we spoke to in November.
So I'm going to pop now to talking a little bit about giving a little bit of background about respirable crystalline silica and related diseases. And so silica, people get confused by the terminology. Silica refers to silicon dioxide, which is the most abundant compound in the Earth's continental crust. It exists in crystalline and amorphous forms. We'll get a little bit into what that is. The crystalline forms, the silicon dioxide, it forms a tetrahedron as a molecule with silicon in the center and the oxygen atoms in the corners. And depending on how it's crystallized, depending on how those tetrahedrons fit together, it can form different kinds of crystals. And one crystalline form is quartz, which is the most common form found in many kinds of rocks. But there are also other forms like cristobalite and tridymite, which are found in volcanic formations. They occur when non-crystalline silica or other forms of crystalline silica are heated. Respirable crystalline silica refers to crystalline silica associated with particles in the respirable size range, so tiny particles that are small enough to be inhaled into the lung. Amorphous forms are non-crystalline, less toxic after inhalation. Examples include diatomite, which are skeletons of prehistoric marine organisms, or vitreous silica. Amorphous silica and quartz, in fact, can be converted to crystalline silica or tridymite by heating. And an industrial example of that is in foundries, where historically in foundries, molds were made out of clay, which contains amorphous silica. And when molten metal is poured into those molds, it converts the amorphous silica in the clay molds into crystalline cristobalite. And then when workers knock the molds off of the metal objects that are created by casting, they get exposures. And here's an example of what I mean by different polymorphs, different types of crystalline silica. So you can see over on the left, you can see the different tetrahedrons. The silicon dioxide tetrahedrons are assembled in one way, and in the middle in tridymite and on the right on cristobalite, you can see that they're assembled together differently. So depending on how these pieces of the puzzle fit together, you get different polymorphs of crystalline silica, and they're all hazardous to inhale. And this is why they're hazardous to inhale, that they're toxic. And there's a variety of mechanisms of action of respirable crystalline silica inducing inflammation and fibrosis in the lung. So silica, when a macrophage, for example, encounters silica, as you can see at about 10 o'clock, there are scavenger receptors that can take up the silica. And then through intracellular pathways, it can go to the NLRP3 inflammasome and lead to caspase activation and generation of IL-1 and other active substances like TNF-alpha, TGF-beta, PDGF, and so on, leading to inflammation and fibrosis. As you can see at about 10 o'clock there, particles of silica also generate reactive oxygen species. So in aqueous solutions, the surface of silica can generate reactive oxygen species that directly can damage cell membranes and result in inflammation. There are also other mechanisms. For example, if you look over at about 2 o'clock, you can see TLR4, and then you can have interactions with that again can lead to downstream inflammation. In that case, NF-kappa B activation. So respirable crystalline silica can attack target cells in the lung after inflammation, including cells such as alveolar macrophages that can generate an environment where there's inflammation and fibrosis. So here are some of the pathologic responses to respirable crystalline silica. And you can see over on the left a silicotic nodule. So in the center, you have these particles of silica, and you get these whorls of fibrosis, and that forms a silicotic nodule. People who inhale lots of silica can get something that looks like alveolar proteinosis, where the lungs fill with proteinaceous fluid. It's called acute silicosis or silicoproteinuria. And the slide on the right was from a historic West Virginia case. It was from a surface driller that was published back in the 1980s who had acute silicosis. One advantage to CTs over regular X-rays is that you can image lymph nodes in the chest really well. And there's evidence from this study that actually lymph node involvement can precede lung involvement. So people can inhale respirable crystalline silica particles in their lungs, can be taken to the lymph nodes. You get lymphadenopathy and the sort of granulomatous inflammation, the silicotic nodules that I showed you earlier in the lymph nodes. And the results from this study with uranium miners suggested that lymph node involvement can precede lung involvement. So what are some of the silica-associated health effects? Well, of course, there is silicosis, which people focus on. That's fibrotic interstitial lung disease caused by these particles in the lung. But there are also a lot of other diseases that are caused by inhaling respirable crystalline silica that shouldn't be forgotten about. It's been established that crystalline silica is a lung carcinogen. It can cause lung cancer. It's not as powerful a carcinogen as, for example, cigarette smoke, but it is a carcinogen. It can cause COPD. It can cause autoimmune diseases. It can cause systemic diseases like rheumatoid arthritis and progressive systemic sclerosis. It can cause chronic renal disease. And finally, people who've been exposed to respirable crystalline silica have increased susceptibility to mycobacterial and fungal pulmonary infection. There are a couple different categories of silicosis. Silicosis can be categorized based on patterns of chest X-ray involvement, or actually patterns of chest radiographic involvement, and by timing. There's so-called simple silicosis, which really isn't simple, but that's the terminology that's been used over the years. There's progressive massive fibrosis, and there's acute silicosis, and we'll show examples. And then there's chronicity. And any of these different chest X-ray patterns, well, actually chest X-ray pattern A or B, simple silicosis or progressive massive fibrosis can occur in chronic or accelerated silicosis. So you can get their findings. The only difference being chronic silicosis is the usual kind. It takes about 10 to 30 years after exposure for it to develop. Accelerated silicosis usually develops with more intense exposure to respirable crystalline silica, and chronic and accelerated silicosis share the same radiographic appearance. Acute silicosis occurs months to years after massive exposure. That's where you have that flooding of the alveoli with proteinaceous material. So here are some examples of what I'm talking about. So here's a case of simple silicosis on the left, and you can see in this classic appearance, multiple small nodules, upper zone predominance. And you can see severe silicosis over on the right, progressive massive fibrosis, where the small nodules coalesce into these large fibrotic masses that you can see in the upper zones. And as they do that, you get contraction and you actually pull the lung up towards the apices, which you can see here. Here's simple and complicated silicosis on CT. You can see here on the upper two panels, you can see simple silicosis. Again, multiple nodules you see on the axial view and the coronal view, worse superiorly than inferiorly. And on the lower panels, you see progressive massive fibrosis, also called complicated silicosis, where you have these large fibrotic masses in the upper zones. So how do you diagnose silicosis? There are three elements in a diagnosis: history of exposure, chest imaging with opacities consistent with silicosis, or rarely pathology consistent with silicosis, and then no underlying diseases that are more likely to be causing the abnormalities. So, for example, miliary mycobacterial disease, that can cause small opacities throughout the lung, fungal infection, lymphangitic spread of cancer, so on. What are the occupational exposures that can cause silicosis? Well, essentially any occupation that disturbs the Earth's crust or involves using or processing silica-containing rock or sand has potential risks. Examples include tunneling, quarrying, stone cutting, foundry work, sandblasting, silica flour production, ceramics production. Foundry work, again, that's because of the molds that become superheated when you pour molten metal into them and create exposures when people knock the molds off. And unexpected new settings continue to be reported, which we'll talk a little bit about in a bit. A little bit about silicosis surveillance and the number of cases that are out there. This is a study that I'm citing because it shows the importance of using health IT and electronic health record-based data to count cases of silicosis. In this study, the investigator looked specifically at Medicare beneficiary data over the period 1999 to 2019. Most cases of silicosis are chronic, last many years, and so many cases persist into the age range when people would collect Medicare, and they develop different definitions based on that Medicare data about what constitutes silicosis. And the most restrictive definition were people who had ICD codes consistent with silicosis, had greater than equal to 2 outpatient or carrier claims, and also had a diagnostic procedure within 30 days before or 30 days after a pneumoconiosis claim that would be associated with silicosis, like a chest X-ray or a CT. And using that most restrictive definition, looking over that period, 1999 to 2019, they identified with the narrow definition 26,000 unique beneficiaries with silicosis. And that's a much larger number of cases than have previously been identified in other ways. And this is just Medicare beneficiaries. So the burden in the US is likely higher. If they went by just principal diagnosis, where the hospitalization or the clinical encounter was primarily due to silicosis, the number is smaller. So 26,000 with silicosis in any position, 6717 where silicosis was the primary reason for the clinical encounter.
Dr. Weissman, on the previous slide, the graphic there,
Sure.
What is the difference between the bar graphs and those dotted lines that have the abbreviation PR after them?
Those are prevalence ratios. These are prevalence ratios, and I'm trying to remember what it's relative to.
Okay.
I will send you the paper, but my main focus for this talk was the bars, which are the prevalence.
Okay.
Now, in terms of the types of industries that have increased risk, the problem with Medicare data and the problem with most electronic health record-based data is there's no information about occupation. And that's been a big NIOSH focus, is to try to get work information into electronic health records. However, there is work information that's present on death records for certain states. Now, you can see here, when you look at this, this is data from these years, 99, 03, 04, 07 to 013 from 26 states. So it's not every state, and it's just, these years, but you can see the markedly lower number of deaths where silicosis caused or contributed to death over that period of time. So death records are a much less sensitive way to pick up silicosis cases than electronic health records. But you can see here that these are the industries and occupations where there were the most deaths. So construction, coal mining, foundries were the industries, and mining machine operators, laborers, and construction laborers were the occupations that had the most number of deaths. So it gives you a sense, again, folks that work with rock and related materials are the ones that are at risk for silicosis. So now I'm going to give some recent examples of work settings associated with respirable crystalline silica exposure and disease. And these are some examples in construction. So for example, tuck pointing, where people go and grind on the mortar between bricks. Out in the Southeast, a lot of folks have cement roof tiles. Cutting cement roof tiles creates, again, these clouds of dust that include small particles that people breathe in, as does tuck pointing. Another emerging area of exposure is hydraulic fracturing. In hydraulic fracturing, one of the parts of the process is moving tons and tons of sand. And so they drill into the ground. They do what's called the horizontal drilling into rocks, into shell formations that contain oil and gas. They put down the liquid to fracture the formation so that they can extract the gas. And the way that they hold the fracture open is by pumping tons and tons of sand into that fracture that they've created so that they can continue to extract gas. And moving these tons and tons of sand creates these clouds of dust. And so there are large potential exposures associated with hydraulic fracturing. We haven't seen cases yet because it's still a pretty new process, but there are certainly potential exposures there. A recent epidemic of silicosis occurred among denim sandblasters. This was from Turkey, where they were making blue jeans and they wanted to give them an aged appearance. So they sandblasted the blue jeans to make them look aged and faded. But the blasting was done without protection for workers. And so Turkey experienced an epidemic of silicosis related to that. So here you can see from an article describing the epidemic. Here on the left, you see a case of somebody with really advanced small opacity disease, all these small opacities. And on the right, you see these massive, large opacities, this person with PMF. In the US, the big new emerging source of silicosis has been engineered stone countertop work. Engineered stone countertops are a relatively new product. They're made by taking quartz particles and gluing them together with resin. And it's a great product from the standpoint of consumer use because it doesn't crack, it doesn't fade. It's pretty indestructible. And people can dye it it can be dyed any color people want. So people really like the product. The problem with it is, as you can see from the chart, the typical product is greater than 93% crystalline silica. And you can see the comparison, say, to sandstone, 60%, granite, 10 to 45%. This actually, in terms of crystalline silica content, has a higher content than most forms of natural rock. And so when people go sawing on it or cutting on it or forming it, they create clouds of dust that's almost all crystalline silica. Another interesting thing about it is because it's a heating process that makes part of the quartz in it gets converted to cristobalite. So some products have a substantial amount of cristobalite. So here's a timeline from a US perspective of the evolution of the epidemic of silicosis that's been related to stone countertop work. And the first cases were reported from Spain in 2011, diagnosed between 29 and 2010 among workers that were involved in making the material. And then in 2012, there were 25 cases reported from Israel, that had reported for transplantation between 97 and 2010. We saw that here in the US and posted in our science blog to raise awareness of the condition, because we figured if this was happening internationally, it would happen in the US too. In 2015, OSHA and NASH together put out a hazard alert. And then in 2015, the first case was diagnosed in the US in a worker in a engineered stone fabrication plant in Texas. It occurred after he had been employed for about 10 years. Then in 2019, 18 cases of silicosis, including 2 fatalities, were reported across 4 states. And many of these, had worked with artificial stone. Among this group of 18 cases, several had autoimmune disease. There was latent TB as well. And then in 2023, there was a large report from California of 52 cases, and 51 were Latino immigrants, mean age 45, median tenure working with the material was 15 years, and 20 of the 52 cases, unfortunately, had PMF. And these were really sad cases. These were folks, many of them were recent immigrants, had no idea that the material that they were working with was hazardous, generated clouds of dust without any respiratory protection, breathed it in, and many wound up with severe disease and actually needing lung transplantation. This is a graphic that we put out after our report of the 18 cases in 2019. And again, silicosis is incurable. It's a disease where the treatment is symptomatic. So really, it's important to prevent it. Working with engineered stone, activities that generate clouds of dust, and really the way to protect against it is to control and monitor exposures, comply with standards, and medical screening and surveillance is really important to detect disease early so people can be removed from exposure. So this is an international epidemic. This is a report from Australia, where in Australia, when they started having this problem, they did mass screening. So this was done in Victoria, where they offered screening to all of the artificial stone countertop workers in that state of Australia. And they invited 993 workers to work, and 717 participated. They did a primary screening in 544 of these, in which they did a chest X-ray and they talked to them about their exposures. And so 100 and so about 130 of these dropped off because they had chest X-rays that showed no evidence of disease, and they had low or they didn't have a lot of estimated silica exposure based on their interviews. So 414 went to secondary screening, and for secondary screening, they did CT scans. And out of this 414, they identified silicosis in 117, simple in 96, complicated in 21, and no silicosis in 297. So out of these 717 that consented to participate in the beginning, 117 turned out to have silicosis. And part of the reason I'm showing this to you is because they also generated some really interesting data comparing the performance of CT to the performance of chest X-ray in identifying disease. And so if you look at the yellow bar here, so among all these guys had chest X-ray, and if you looked at CT as the gold standard, chest X-ray only had a sensitivity of about 67% in picking up silicosis cases and a specificity of 86%. So there was a fair number of cases that weren't picked up by chest X-ray, And there were a fair proportion of cases, although less so, where the chest X-ray suggested the presence of silicosis, but the CT showed something else. And for lung function testing in this group that got screened, there was low sensitivity but high specificity for the presence of silicosis. So really interesting and unique data. And in fact, based on data like that, Australia has been very aggressive about deploying low-dose CT scanning as a way to screen dust-exposed workers for the presence of pneumoconiosis. So, for example, in 2021, the Western Australian government passed legislation requiring low-dose HRCT be used for silica health surveillance for detecting and preventing silicosis. And they got into the details of how much radiation and the slice thickness and that kind of thing. But the bottom line is, because of the greater sensitivity of CT, they've deployed it a lot more in health screening and surveillance of workers than we have in the US. So if you look at the report of 52 cases in the US, and the investigators here who reported this from Los Angeles looked at the year that disease started in their series, there's been a marked increase over time, and this parallels the increase in the use of artificial stone. And here are some of the features of that US outbreak from Los Angeles. You can see the symptoms here. So shortness of breath, cough, chest pain were some of the things that were seen. Some of the cases were asymptomatic. Several of their cases had autoimmune disease. One issue about their population is because so many of the folks came from high prevalence countries in Central America. They saw a fair number of cases with a history of active TB. They also saw non-tuberculous mycobacterial infection. In terms of the CT pattern, again, 62% simple. Unfortunately, 38% were caught at the point of having progressive massive fibrosis. And you can see some of the CT appearances that are here on the table. So prevention is really where it's at in this disease. Again, there's only symptomatic treatment. The role of antifibrotics like nintedanib and pirfenidone is unclear. The role of inhaled treprostinil if folks have pulmonary hypertension it hasn't been studied in this specific condition. So really, it's just symptomatic treatment, making sure people have their vaccinations, making sure people get treated for infections if they get them, giving them oxygen if they need it. It's that kind of thing. And if people are bad enough, lung transplantation. So it's really all about prevention in this disease. And prevention follows what we call the hierarchy of controls, where the highest part of the hierarchy is eliminating the hazard. And in fact, in Australia, what they've decided to do is they've decided to ban the use of artificial stone countertops that contain crystalline silica. So I think their threshold is like 1%. If artificial stone has more than 1% crystalline silica in it, they don't allow it to be used in the country anymore. And the manufacturers have been developing new products that use crushed glass instead of crystalline silica in them. Substitution is the next level of the hierarchy of controls. So using something instead that's less hazardous. Engineering controls. So you can do things like ventilation controls, like source control. So at the location of the tool that's generating the dust, sucking the dust off, or ventilation would be examples of engineering controls. Administrative controls, changing the way people work. So for example, if you're going to get rid of dust on the work site, use HEPA vacuums, don't do dry sweeping, that kind of thing. And then personal protective equipment, respirators are needed often for the types of jobs people do, because often it's not possible through engineering controls to get the exposures low enough. So there is a relatively new silica rule that was promulgated by the Occupational Safety and Health Administration in 2016. It sets an action level of 25 micrograms per meter cubed measured over an 8-hour period, where if you have workers that are going to go above that level, you have to do special measures in terms of measuring exposures and controlling them and providing surveillance. There's a permissible exposure limit that's not to be exceeded of 50 micrograms per meter cubed. And again, I talked about the hierarchy of controls before. Other things that are in the rule are the requirement for medical surveillance. Workers that are exposed to the action level for 30 or more days per year, or are required to wear a respirator for 30 days or more per year, are required to be offered chest x-rays and spirometry every 3 years. It's also important to train workers and to provide and to keep records of exposure measurements and documenting that medical exams were provided. And in 2024, this year, the Mining Safety and Health Administration, MSHA, promulgated a rule that's similar to OSHA's rule for general industry, except for miners. So now miners have the same protections that a general industry and construction had before. California, after that outbreak that I showed you, put in an emergency temporary silica standard that they have a state OSHA. And again, they're really focusing on controlling this exposure using the same general approaches that I talked about earlier. One thing about the California standard is they require vapor protection in addition to particle protection for artificial stone, because artificial stonework does generate some VOCs because of the heating of the resin that's used to hold the bits of crystalline silica together. So that's one thing that's different about that state rule than the national rule. And again, as I mentioned earlier, Australia has banned engineered stone work, and that ban went into place July 2024. So industry is supplying completely different product now to Australia than to the rest of the world. So I'll just finish up really quickly and say that inhaling respirable crystalline silica causes a spectrum of respiratory and systemic disease. Silicosis surveillance documents that we're still having cases of silicosis in the US. And the bit of data we have suggests to me that data from healthcare payers and providers has the potential to improve our identification of the burden disease at the population level. Respirable crystalline silica exposure and outbreaks continue to occur in settings where the hazard is not anticipated, recognized, or controlled. And silicosis in engineered stone workers is an important contemporary example. And high-resolution chest computed tomography detects silicosis with greater sensitivity than chest x-rays. And silicosis is preventable. And one last thing I'll add, since Grace Ann pointed out the interview that Ted Koppel did, silica has played a really important role in the resurgence of coal workers' pneumoconiosis that we've had in West Virginia and other Appalachian states, where miners have been chewing through stone formations to get at coal seams and generating crystalline silica exposures. And so, many of the rapid cases of rapid progressive pneumoconiosis that we've seen in coal miners in recent years in West Virginia and neighboring states really probably are accelerated silicosis. So I'll stop just by saying that NASH offers health hazard evaluations. So if you encounter what you think are workplace outbreaks of silicosis, and either the employer or 3 or more workers or a union want evaluation for potential hazards and recommendation of solutions for that workplace, we have this health hazard evaluation program, and that can be requested online. So I'll stop right there and take any questions.
David, looking at the that new contemporary exposure, one thing that kind of struck me is, one of the risks for silicosis, I'm not sure if you mentioned it or not, is the freshly fractured silicosis. And I just think about those guys grinding that tabletop. Like, I wondered if you, it wasn't clear from the Australian data if you'd see more accelerated silicosis in that group, because it really just silica that is freshly fractured.
Yeah, and the deal with fresh fractured silicosis is that you expose the crystalline, face, and then that generates more reactive oxygen species in aqueous solution. So it's much more potent in terms of inducing acute inflammation. And then older, older particles, that are coated, they're less likely to generate reactive oxygen species. So people think of things like sandblasting, and cutting and generating, fresh particles, as being especially hazardous, especially from the standpoint of acute inflammation. In our stuff in the U.S., I think one of the slides I mentioned that it was like a 15-year, average period of work for folks. I know in Australia, many of the workers are younger, so they probably were more accelerated than chronic, and a lot of them had really advanced disease, so yeah, it's just really bad stuff.
I think Grace Ann has her hand.
Yes, I do. David, from what I understand, and it may be an incomplete understanding, I've read the regulations, the new regulations on the silica as applied to coal miners. The regulations have no teeth, which is what everyone was complaining about. And it seems to me that if the regulations still stand for both black lung and silicosis, where you're dependent essentially on relying on chest x-rays, and from your presentation, we all know you're not capturing many of the people who are out there. What are your recommendations as to what can be done in terms of raising the level of awareness about this problem in West Virginia in particular?
Yeah, and I think the black lung clinics play a really important role in that, and from the standpoint of the exposures, we've heard from Chris Williamson in MCHA, that MCHA is going to be aggressively in the mines, to continue to do, sampling. So it's not going to be like totally dependent on operator, sampling, because MCHA is going to be sampling too, at least according to what we've been told. But I know MCHA is really aggressively, out there, talking to operators and talking to the unions about the rule. From the standpoint of surveillance, there's no doubt that we're missing people who have mild disease at early stages of disease. I won't say mild, but people who have early stages of disease that could be caught earlier, and have that information to be able to work with. If we use CT over chest X-ray, chest X-ray in many of these settings misses about 30% of the cases of less advanced disease. And so I do think that if we had the ability to wire, low dose CT into our surveillance scheme, it would be really useful, especially for longer tenured coal miners, where the likelihood of identifying disease would be higher. I mean, I would love to be able to offer people, CTs, even if we can't afford to do it, like for, like every 5 years, it would be great to be able to offer people 10, 15, 20, end of career, so they know if they have disease, and if they're starting to get disease, they at least have the opportunity to request a lower dust job, because they can do that under Part 90, with a CT. So I would love to be able to offer it. And I've been trying to advocate for that. But without funding, it's not something that we can make happen. So that's kind of where that's at. There's no doubt we would pick up more cases earlier and arm miners with the ability to make decisions about their health earlier if we wired that into what we did.
David, I was actually talking to Stella. I mean, you heard Kyle's talk on the Lucas bus that's going around. I mean, I wonder if there'd be potentially an interesting NIOSH WVU collaboration there, because the cost might not be quite as much if you already have the tractor trailer with the CT in it, and it's going out to communities anyway. Maybe there would be a chance to get something funded. Just a thought.
Yeah, and that would be great. And I remember that he did comment that for those that don't have resources, that the cost is about $200. So I mean, it wouldn't cost much to do a pilot that could enroll a fair number of miners. I mean, so it would be great to do something like that. Yeah, and then we could catch nodules, which is the primary purpose of that unit, but also catch interstitial disease and give people counseling on that. So absolutely, that'd be fantastic to do that.
Sounds good. I have just one follow-up, David. It's my understanding, and correct me if I'm wrong, that to this day, operators still have advance notice when the inspectors are coming to do sampling and so on. And it's my sense that so long as that exists, that the sampling itself is not reliable.
Yeah, and they try to address that in the rule by talking about having to do sampling when your operation is running at normal levels, but so they try to address that, but absolutely, if people are able to game the system, and then the apparent measurements you take don't reflect what people are really exposed to, and I would defer to MSHA to talk about kind of how they're addressing that, but the regulation does try to address that situation.
Carl, were you going to talk or ask something? Okay, I know our time is very, very short. As usual, I have tons of questions about the biology and the pathology of this, David. Thanks. It was really interesting. But since time is short, I just want to mention that the West Virginia Black Lung Association right now has been doing public forums, community forums on coal miners' rights, which are directly related to trying to inform miners and their families about the Part 90 option, which allows a miner to transfer out of a dusty environment. The operator is required to give him or her a less dusty working condition if they have demonstrated evidence, I think, of early silica disease and not just advanced. So that's really important. We just had one of those forums here at New River last Thursday. About 30 people attended. It was really good. MSHA was there. NIOSH was there. Noemi, what's her last name? She was there with lung models. So that was great. And the other thing I just want to mention is that I'm really happy that 4 of the Grace Dan Dorney pulmonary rehab sites are at this presentation today, and another 3. We've had a great turnout today. Dorney Coppell sites and APHP sites. I'm giving Carl credit for being here for Cabin Creek. I'm here for New River. Brandy Bell is here for Southern West Virginia Health Systems Mullins. Johnny's here for Southern West Virginia Health Systems Logan, and that is a Black Lung Clinic site. New River and Cabin Creek are. Dean Gunter, welcome back, is here from Pocahontas. Terry Hauser from Preston, and Diane Nichols from Somersville. So I'm really glad that people showed up and got to hear this. And it also tells me, Kelly, that we're working out the bugs in the registration system for ECHO. So thanks, everybody.
Thank you for that, Dr. Doyle. And I am thankful for everyone that was able to join with us today. Some exciting news while you've been bringing some stuff up. Our next session is going to be September 16th, and it's going to be on lung cancer. And that'll be by Dr. Kyle Chapman. And I do believe it is in October. Per our request whenever we discussed before, we will be having, I think it's a doctor from UPMC discussing with us on lung transplant, and it'll be a member of the team. So I've been working hard to try to make sure we get you guys stuff that you would like to hear about and keep you guys interested.
Hey, Kelly, did you catch where Sandy Brundage was from? Or does anybody know?
I haven't.
She just signed off.
Yeah, she is WVU medicine, I believe, out of Morgantown.
Okay, great. Thanks.
So, all right. Thank you all for joining us today, and I will see you guys on September 16th.
Thank you.
We forgot to mention this is our first noontime echo, or at least it is for this lung disease group. So that's another another milestone, and it seems like it worked.
I'm glad.
Yep. Okay. Take care.
You as well.